These are the PowerPoint slides that coincide with the health assessment of the heart, the physical examination. These are the PowerPoint slides that coincide with the health assessment of the heart, the physical examination. These are the PowerPoint slides that coincide with the health assessment of the heart, the physical examination. In this lesson, we will learn what we can observe, palpate, and auscultate that can tell us about each patient's heart. How we educate our patients may make a difference in the future of these statistics. You'll notice that this slide is from the Center for Disease Control and Prevention, and it's from 2002. This is just a general review of your anatomy of your heart. You had a homework assignment which included a blood flow map that you made. If you'll get your blood flow map out, you can compare as we go over this structure of the heart if you did it correctly. Someone tell me what number 1 is. That's correct. The superior vena cava, returning blood to the heart from the head. Someone tell me what number 2 is. The pulmonary artery, going to the lungs to exchange gases. And number 3, the pulmonary veins. That's right. Number 4, the mitral valve. Number 5, the aortic valve. And number 6, the aorta. And number 7, the pulmonic valve. Number 8, the left atrium. Number 9, the right atrium. And number 10, the aorta, and from there into the systemic system with oxygenated blood. Number 11. Heart sounds are heard by auscultation, and if they are normal, the first 2 sounds heard will be the heart valves closing. Take your stethoscope, and everyone be very quiet. Place the diaphragm over your heart where you can hear the lub-dub. Listen for a minute. As you see on this graph, S1 is a dull, low-pitched lub, less intensity than S2. If you listen on the aortic valve, if you listen on the pulmonic valve, it's still less intensity than S2. If you listen on the tricuspid, it's louder than or equal to S2. And listening in the mitral area, it's louder than or equal to S2. Systole is normally silent interval between S1 and S2. S2 is a higher pitch than S1. It's the dub. And if it's heard over the aortic valve, it's louder than S1. On the pulmonic valve, it's louder than S1. Abnormal if louder than the aortic S2 in adults over 40. The tricuspid valve, it'll be less intense than or equal to S1, and less intense than or equal to S1. So, listen for a minute, then distinguish the first sound, which is S1. This is the AV and ventricular valves, the tricuspid and the mitral, closing as they finish filling the ventricles. Even though these 2 valves don't close simultaneously, it's close enough for you to hear the S1 to be heard as one sound. Now listen. Did you hear the lub of your first heart sound? After the ventricles empty the blood into the aorta and pulmonary arteries through the semilunar valves, the aortic valve inside the aorta coming out of the left ventricle, and the pulmonic valve inside the pulmonary artery coming out of the right ventricle, you can hear the second heart sound known as S2 when these valves close. This is the dub. Now listen. Did you notice that S2 has a higher pitch to it than S1, which is low and dull sounding? Listen again. Did you notice this time the difference in the sounds of S1 and 2? These heart sounds can be heard anywhere over the precordial area, but are heard best at the anatomic sites which we will listen to after lecture on our volunteer patient. Each site is associated with the closure of a heart valve. Associated with these heart sounds is systole and diastole. When the ventricles contract, that produces the pressure of systole, your top number in. Where would you think the semi-reclining position would be? That's correct, 45-degree angle. Where is the supine position? At 0. That is correct. These are the general anatomical sites where the valves can best be heard. We will move your stethoscope slowly around to where you can hear them the best when we listen on our volunteer patient. Underneath the second rib is the second intercostal space on both sides of the sternum. To the right side is the aortic area where you can auscultate, and to the left side is the pulmonic area. From the pulmonic area, move down with your fingertip 3 intercostal spaces where you will be at the fifth intercostal space on the left of the sternum. Here you will locate the tricuspid valve, which is orange on the power cord. From the tricuspid valve, move your fingertip laterally 2 to 3 inches to the left, mid-clavicular line, and you reach the apical or mitral valve area. Also, this is the point of maximal impulse, or point of maximal impulse that was noted before. The patient may need to be repositioned to left lateral to really hear the point of maximal impulse at its best. Inspect and palpate these anatomic sites and note any pulsifications which would be an abnormal finding and may indicate enlargement of the ventricular examen. If the apical location is displaced, note the distance between the apex and the mid-clavicular line in centimeters. Auscultation can be performed after we have done ribs have been observed and palpated. We will drape the patient with the waist. Make sure the room is quiet because heart sounds are loud and any outside noises impede the exam. Using the same anatomical landmarks as used for palpation and observation, listen to both S1 and S2. Concentrate on these sounds separately. The first heart sound, S1, followed by systole. The second heart sound, S2, followed by diastole. Repeat the exam introductions sitting in an upright position if you have not heard them. Sometimes sounds can be heard in different positions better. S1 and S2 can normally be heard at the size if the heart rate is between 60 and 100 beats per minute. Abnormalities may include increased or decreased intensity of the beats or sharp sounding clicks. As stated before, S3 can be normal in children and young adults and abnormal in older people. S4 in older adults can be an indication of hypertension. Returning to this slide, we can see once again what we expect to hear. This is the slide that we'll use when we come back for demonstration so that you can see where you can locate on your volunteer patient. You will be starting up at the angle of Louis at the top. Take time for a break now, 10 minutes, and when you return, we will demonstrate the anatomic sites on our volunteer patient, and you can each take turns listening and observing and palpating, which you will do first. Don't forget to turn in your evaluations and scenario of critical thinking. Tomorrow's homework assignment is on the board.